think maybe Anna will introduce our presenter for today. Really excited to have Lady with us and the work we have here.
Hey, good morning, everybody. Well, I'm happy to introduce Niti Saripalli. She's a first-year master's student in the Global Health program and is going to talk today about her thesis project and her fieldwork that she's going to be doing in North Carolina this summer.
Hi, everyone. Good morning. Is my screen visible?
Yep. Perfect.
Is it still okay?
Yeah, it's great.
So good morning, everyone. I am Nidhi Saripalli, and I'll be talking about my research proposal today. It's titled NC4Health, a community-engaged mixed method study of disaster preparedness in North Carolina based on the social determinants of health. So the rationale kind of for the study comes from the problem of how climate disasters are a growing public health crisis. We have literature that says that the annual rate of climate-related disasters in North Carolina has tripled. And the recent Hurricane Helene in September 2024 was a devastating show of what actually it can do. There were more than 108 deaths and more than $59 billion in damages from one hurricane alone. And entire communities were cut off from healthcare, power, and communication for weeks. But the key thing to note here is that devastation was not felt equally. The communities that had the fewest resources going in, such as those facing poverty, housing instability, and limited healthcare access, those were the communities that bore the greatest burden of this disaster. This is what the social determinants of health are, and the communities lacked adaptable response systems. So this study kind of tries to address this problem. And my study has two aims. The first is to create a statewide resource map, which is like a database of every community-based organization, every EMS agency and government body that works in some or all phases of the disaster life cycle in North Carolina. And the second is to conduct a gaps and needs assessment, because it's not enough to know what exists, but we also need to understand what is missing, where organizations are stretched thin, and also where there are opportunities for collaboration that are not happening yet. So the main research question for the study is, how do community stakeholders operationalize disaster resilience? And continuing to that is, what gaps, resources, and implementation barriers shape their capacity to prepare for and respond to SDOH-based needs of the community during disasters. So we are basing this study on 4 implementation science frameworks. The first is community engaged research framework, which is based on principles like shared decision making, transparency, where the community will have a say in what the resource map looks like, for example. Then there is the RE-AIM framework, which is research effectiveness, adoption, implementation, and maintenance, which will guide the planning and development of the resource map and also frame the focus group discussion guides. The third is CFIR 2.0, in its 5 domains of innovation, outer and inner setting, individuals, implementation process, which will structure the code book and make sure that our qualitative analysis is able to capture organizational and contextual factors. And the fourth is social determinants of health, which captures social, economic, and environmental factors that lead to disproportionate effects of disasters across health equity dimensions. So, my study is a community engaged explanatory sequential mixed method study, which basically means that the quantitative findings will guide the qualitative data collection to evaluate the preparedness for disaster relief in order to specifically address SDOH based needs. The overall project will be done in 3 stages. The first is the pilot stage, where we will be using Hurricane Helene as a case study. The second is implementation, where the project and the resource map will be scaled statewide and revised and expanded based on feedback from the community partners. And third stage is sustainability, where the long-term goal is to form a community academic coalition, which we are calling Duke NC4Health. This will work for long-term disaster preparedness and health system resilience. However, my own research proposal or thesis will focus on the first stage, which is the pilot stage. Coming to the study population and sampling, so we have a total of 275 organizations or individuals that form the initial pool of the sample, of which we have identified 245 community-based organizations with the help of the Duke Library access to the GuideStar Pro non-profit database, along with 15 county EMS directors and 15 emergency management coordinators from state agencies. So these are the 15 most affected counties in Western North Carolina that were affected most by Hurricane Helene. So just to give a little bit of background, out of the 39 North Carolina counties that received a federal disaster declaration during Helene, we will sample the 15 counties that were categorized by the North Carolina Office of State Budget and Management as suffering critical levels of business disruption, where OSBM, or the Office of State Budget and Management, categorizes these 15 counties as FEMA designated, and also uptake of individual assistance, such as which act as a proxy for workforce disruption and displacement, duration and severity of electrical power outages, search and rescue based damage estimates, and also the duration of county school closures. The exclusion criteria is basically volunteer organizations who were deployed from other states to assist in rescue and relief during Hurricane Helene, because they would not be aware of the long-standing needs of the local communities. So data collection, we will be using a mixed methods design where the electronic surveys and focus groups will be employed, and the two methods are aimed to complement each other. The survey, the quantitative part will be the electronic surveys, which captures the organizational demographics, scope of services organized by SDOH domain, funding mechanisms, and perceived gaps using the REAM as the framework. All of this feeds directly into the resource map, and also the gaps and needs analysis. And then the qualitative or the focus groups and interviews will focus on who this the resources should reach, how they should reach, and what information should be included in the resource map. In the focus groups, we will be doing like 5 to 10 participants per focus group in 45 to 90-minute sessions. This will be either electronic or an in-person format. And it will be based on REAM and CFIR 2.0. These conversations will be audio recorded, and a total of 36 to 45 participants will be included. Why this number is because research suggests that over 90% of themes emerge within the first 12 interviews, but because we have different interest holder groups like CBOs, state agencies, and EMS groups, we are anticipating approximately 36 to 45 qualitative study participants. For the data analysis plan, so the survey data will be analyzed descriptively in RStudio, including frequencies, percentages, and central tendencies. The geographic data will also be visualized as an interactive geospatial map. And most importantly, the final structure of the resource map will be co-designed with our stage 1 partners so that the community gets a real input into how the tool looks and works. For the qualitative data, we will be using a rapid qualitative analysis approach uh, with a predefined codebook and emerging codes from 2 independent coders. Discrepancies will be resolved by the PI, and saturation should be confirmed at around 36 interviews. We will also be doing a member checking thing where the findings will be shared back with the participants for feedback. The anticipated results of the study are a resource map, firstly, which should be a virtual geospatial database of organizations across the disaster lifecycle, which will also be filterable by SDOH domain and county, for example, education, nutrition, and other social and environmental factors. The second will be a gaps and needs report, which will be a comprehensive assessment identifying where the resources are missing and where cross-sector collaboration can be done. The third is a stakeholder network, identified key collaborators and community champions for sustained engagement beyond the study period. So we are hoping to have a community advisory board by the end of this year to then help us scale and build the Duke NC4Health Coalition, which is a community academic partnership with practice, policy, education, and research pillars. The innovation and significance that we think are important about the study is firstly the application of implementation science frameworks, where we see a lot of literature that that includes IS studies that evaluate disaster preparedness after a disaster, whereas this one is actually helping in the planning and design phases. The second is equity-centered design, because we are using the SDOH framework, which anchors the resource map. This tries to ensure that underserved communities and underrepresented service areas are explicitly surfaced and prioritized. Third is the basis of the study on a real world scenario. This generates immediately actionable insights for communities that are still recovering from the aftermath of the disaster. And fourth is a scalable and sustainable coalition model, where the Duke NC4Health is designed from the outset for a long-term sustainability and built on these IS frameworks. However, there are certain limitations in ethics. So the first limitation that I could think of was recall bias, because this is all self-reported data post-disaster, which may also be traumatic. And we will try to address this with iterative analysis and saturation strategies. Another limitation per se is that the initial data collection will be in English only, because in this stage we are talking to state EMS and CBO representatives. Therefore, we can assume that they speak English as their organization's operating language is in English. But however, for dissemination of the findings and inclusion of community members in the later stages, using English as the only language would not be appropriate. In terms of ethical safeguards, the study has been determined exempt by the Duke University Health System IRB. Electronic informed consent will be obtained from all participants. Confidentiality will be protected by unique identification numbers that will be assigned to all the participants. Strobe and correct reporting guidelines will be followed, and participants will also be compensated for their time. So to conclude and summarize, this study is important because building resilient systems is the need of the hour, especially in times of climate disaster that are increasing by the day. The study integrates community engagement and implementation science for context-specific solutions. And Hurricane Helene as a real world case study creates immediately actionable findings. And most importantly, the Duke NC4Health Coalition will outlast the study and drive long term disaster preparedness. I'd like to acknowledge that the project is funded through the Climate and Health Research Initiative, and also like to thank Dr. Staten for her support with this project and Paige for sharing her IS expertise. Thank you, and I'd love to hear some suggestions or feedback about this study, and especially the methodology or the data collection part. Thank you.
Excellent. Thank you so much. Congrats to you and the team for this great proposal. So yeah, let's hear if folks online or in the room have some feedback, some questions or suggestions. It's great to share them at this stage in the work before we get too far. If you have some constructive criticism or any feedback, go for it. Yeah, go ahead, Eduardo.
First of all, congratulations for you and the team for great choice and great work we're planning to do. I'm also working with climate resilience and emergency medical services preparedness and response. I'd like to know what are the main social determinants of health you're thinking about working with, and how you plan to work on the analysis of those and your findings. Thank you.
So the social determinants of health that we are including are, like I said, education, nutrition, healthcare access, and to kind of answer how we are going to analyze that. Um, if Anna could help with that.
Sure. Yeah. Thanks, Eduardo. So we're using the social determinants. We're using all 5 main categories to be able to, in the resource map, basically create a filter, right? So that we can say there's community organizations that work on healthcare access and quality, so that if that community organization might also be looking for somebody else who works in that area, they can search for that. Same thing with education access or economic stability, so that we're able to say, can we see which organizations cover which areas and potentially are also overlapping? That's mostly for the kind of main deliverable of having that resource map to make it usable for the community partners. In terms of analysis, right now what we're thinking about doing is to use the social determinants mostly descriptively to say, where do we actually see gaps, right? So if we're saying that there's, in this whole area, there's only one organization that focuses on social and community connectedness, but it really covers, basically the whole state, then that allows us to say, okay, maybe that's something that other agencies are able to cover as well. So it's mostly to structure our resource map. But I'd be curious to hear your thoughts or suggestions you have for the analysis, to potentially do subgroup analyses or something like that.
Okay. Thank you. Thank you, Edie. Thank you, Anna. I would love to talk about this later. We also have some pretty interesting metrics we use in Brazil for those. And with our primary care system, it's usually interesting to associate some of those metrics with the events we see. And I think I have some ideas. Maybe we can discuss this later. I'll be happy to do this.
That'd be great. Yeah, I'll reach out to you on by email to see if we can set up a meeting. Thank you. Catherine, go ahead.
Excellent. Well, Needy, great job, great presentation, really very, very clear. And great job to Erin and Anna for really thinking through this project and bringing it to life. The comment that I was going to make is going to be about all the different frameworks. When you first presented them, I got really nervous about how they were going to all fit together, but I think each one of them has a role in the project, and I think they're very well justified. One thing I would try to think through is try to think through an organizational structure where you could demonstrate visually how they fit together. Usually, we try to make an argument that there's one framework that's the baseline framework, and then you bring others in for certain areas. And I think that you talked through it a little bit, but I think that there could be more work in that area to just demonstrate how they each fit, because I think that you might use more than one of them in more than one area just because of the initial identification of the population analysis components, etc. And so that might be really helpful throughout the life of the project to just demonstrate what you're using when and why, because I think that'll be helpful to those who are trying to understand what it looks like, how it all fits together. But really nicely done.
Thank you.
If you have other questions or comments, feel free to put in the chat or you can unmute and share. I have just one thing to consider, and maybe it's a little bit nitpicky or something, but something that I'm thinking about. I mean, the Helene example is still quite recent, although it's getting further in time as we go along, you know. It'll be more than 2 years by the time you finish with the project, which isn't long in the case of science, but it kind of is long when you're talking about community resources and things like that. So what I was thinking about as you were going through is, you know, thinking back to my experience from afar of taking in some of these stories from this case is I could see that the resources that were available and were mobilized in Helene may not be the same anymore. That may be for a positive and a negative reason. Negative being these community-based organizations were tapped out, and some of them maybe don't even exist anymore, or you know, they need some time to rebuild their stockpiles and their probably financial resources and all kinds of things. But on the positive side, if we're going to be idealistic, perhaps there were some very obvious gaps that didn't need this wonderful systematic approach to identify, right? It's some of these things became very obvious straight away that there were gaps. I'm glad that you'll take a systematic approach to identify this more objectively, but perhaps some of those identified gaps have been filled or plans have been made to mobilize things. So I'm just wondering, with the inevitable limitation that this is as close to real time, but it's not actually real time. You know, how do you plan to address that, or what kind of considerations are you guys taking about that?
So I think we have not yet piloted our the survey questionnaire, but it's kind of still being finalized. But what I can say is that there are questions that in the survey that do not pertain specifically to Helene. So I feel like the data that we will get from that will be like present data.
Yeah.
However, we do have some parts of it that ask questions directly about Helene, which I mean, I think that should kind of balance it out.
Yeah. Well,
Yeah,
I
don't know if that.
No, I like that. I think it's great that you guys are going to pilot, because then you're going to probably figure some of these things out when someone says, well, do you mean what was available then or what's available now? So getting that clarity is going to help with your data collection, because the interpretation would vary potentially.
Right.
Yeah, maybe just to add to that, Needy, you're exactly right. So what we're what we're aiming to do is, yes, we're piloting with Hurricane Helene, exactly for that reason, right? There are a lot of probably lessons learned of saying, I didn't know we needed that until you needed it. Or we actually learned to expand our, footprint of our organization to include certain areas. So a lot of the questions that we're going to be asking, and because we're piloting this now, the survey itself is not going to be Helene specific, but as we are expanding to across North Carolina, we're asking, for example, about did your organization participate or was active during any of the last 10-year federally recognized disasters, right? And then they can choose. So right now in the pilot, everybody will say Helene, but as we're going towards more of the coastal areas, for example, we're asking the same questions about in responding or preparing for those disasters, what have you learned about how to adapt, or what resources are needed to meet that specifically?
Great. Any other comments, suggestions, questions, any concerns that you have, Nidhi or Anna, that you'd like to ask of the wisdom of the crowd before you go forward?
I mean, my most concern, that's exactly what Catherine already spoke on, is making sure that the frameworks used are helpful and not confusing, and that it's not, we're not getting lost in the weeds of trying so hard to have all the frameworks in, but making sure that they're specific and targeted. So we're Needy's starting her field work now, so we'll have her for the next 10 weeks to really pilot. We have some really, really helpful kind of content experts to pilot it with, but yeah, would love to hear more once we kind of have maybe the first draft of the data collection tools for feedback in the group. That'd be great.
Awesome. Great. Well, join me in thanking Nidhi and the team. We appreciate you joining us, and you're welcome to come back and reach out anytime for some of that feedback.